everyone. I just want to give you my opinion on weaning. We know traditionally when we wean patients, sometimes patients, they'll put them on PEEP of 5, pressure support of 6, okay? When they're on that level, they have normal blood gases, no significant work of breathing. They're looking good on these parameters. That's one way the doctors in ICU extubate. So, you know, PEEP of 5, pressure support of 6, that little pressure support of 6 is to compensate for the resistance through the ET tube. We're breathing through a very narrow tube, okay? And we need a little bit of that pressure to compensate for the resistance. Don't forget that we have an ET tube, right? That's in the mouth. If we disconnect the ventilator, that tube is directly in the lung, okay? You can't close your your glottis or anything like that. So you equalize the pressure. Normally, like me, you, everyone here that's listening to the video, we have, in pulmonary function tests, we have our pulmonary PFTs, right? We have our functional residual capacity, and that keeps the lung open in a nice compliant area, naturally, physiologically, and that is lost once we put a tube, into the lung. So we must artificially set this FRC for the patient, and we use the PEEP, right, for that parameter. So now that they have electrical impedance tomography at my hospital, I use the Tomography. I'm starting to realize that ideal PEEPs, when I do the PEEP trials, are often 10, 12. These are people that might be on 21%, and their ideal PEEP to maintain the ideal compliance on that pressure volume loop sometimes is 12. And when you look at it, it makes sense. Let's say you have a 21% FiO2, the guy has nice volumes, he's breathing slow, but he has ascites, but he has what you would be pretty sure that there's some kind of increase in intrapleural pressure. So traditionally, we didn't care. Oh, he's on 21% and he tolerates that with a PEEP of 5, great, now I'm confident. So what we're doing is we're challenging the organ. We're challenging the lung to see, and we say, well, we're putting more stress than we think might actually be when we extubate, and if they're able to tolerate that, then they have a good reserve. But not keeping in mind that we just exhausted our patient and now we're gonna pull the tube. Some doctors and methods are like T-piece, like that's literally just putting oxygen on. No more PEEP at all. Complete loss of your PEEP, complete de-recruitment. And if that patient actually pulls that off, then we extubate. And I feel that that will lead to many, many reintubations. The lung is the only organ that in the medical field, we almost like hurt a little bit before we ask it to resume its job. We don't stress the liver, we don't stress the kidneys and stuff like that. Yet when we're intubated, especially just before we're going to take the support off, we're going to collapse everything. We're going to de-recruit everything. So now that we have the Tomography, we're realizing that ideal PEEPs, are quite higher than we thought. There's nobody, I don't think, so far I've seen nobody with a good PEEP level that's optimal with 5. Nobody. Okay, so far I've never seen that with the Tomography. 6 either, often 8. So at our hospital, we without like the order for mechanical ventilation to start is the RT can set it between 6 and 8. We did this before the Tomography arrived. I just knew that for sure 5 in my mind is not good. Okay, so what I'm trying to say is, if you do challenge the lung, okay, do not extubate, okay, once you tell the doctor, oh, the patient tolerated well, okay, you can extubate, and then you pull it. The patient's de-recruited, and now you're gonna ask them to maintain, okay, an optimal FRC when you extubate them and they're possibly collapsed. When as a respiratory therapist, that you can't re-expand your lung, even with PEEP, right? If there's a significant collapse in an area of your lung, you need a recruitment maneuver to open that up, and then we set a ideal PEEP to maintain that splinted open. So I think that we had no choice but to do this because we had limited information. In the past, before tomography, we had to challenge the patients. Okay, it was our only way of knowing if could they tolerate it. Well, we challenged them pretty good and they lasted. The chances are, that's helping us understand. But now we have direct tomography. We have direct visualization, okay, of the distribution of each tidal volume that's being delivered. Therefore, in my mind, and what I'm trying to adopt in my practice is the Palma Vista during the weaning phase, especially prior to extubation. I think it's labor intensive to have to put on this belt and stuff like that, but we should optimize that PEEP. If the doctor wants to challenge the patient, that's fine. Okay, let's challenge the patient. TPs, whatever you want, okay? Zero PEEP, zero pressure support, tube comp, whatever you want. But after, if you're an RT, try and convince your ICU doctor to allow you to recruit, to allow you to optimize that patient's PEEP before pulling it out. If that patient has to go back up to a PEEP of 14 for an hour, where the Palma Vista is saying that you're getting a recruitment, the distribution is optimal, that patient should be extubated, in my opinion, at that level. Because to do anything lower than optimal PEEP is literally stressing an organ before you ask it to resume its job. We need to optimize the lung, and with the Palma Vista, there's no more need to challenge. What we should be looking at is saying, okay, look, this patient is totally weaned, pressure support's minimal, they're on a PEEP of 12, blood gases are awesome, the pathology has resolved itself. Now we want to pull the tube out. What we should do is look and say to ourselves, well, yeah, the guy needs, 14. If it's 14, the doctor wants to challenge, that's fine, but you're going to end up re-optimizing that patient. And if they get back to 14, I don't see a problem extubating them on 14, because that patient, the question that we don't know is, once I pull that tube, is the patient going to maintain that recruitment? So we got to start with an optimized PEEP. We have to set that patient in the pressure volume loop in the most compliant area just before pulling the tube. So with the Palma Vista, I don't feel that we need to challenge the patient anymore. I think it's not bad that we were doing that. I think we had no choice because we were limited in the information. Don't forget that before the Palma Vista, 400 tidal volume, okay, is 400, fine. But we don't know where that 400 is going. The Palma Vista is really surprising me. The things that I kind of imagined were happening with what I was setting, it's completely different. I think the Palma Vista is going to revolutionize respiratory therapy and ICU ICU mechanical ventilation and the respiratory care scene. We can put the Palma Vista on a patient, let's say that is difficult to wean, that has a tracheostomy, and I think we should put it on and look how they are, and then we should keep that on and see if they're de-recruiting. This is stuff that we could never have known. We were just looking at the work of breathing, looking at DSATs and stuff like that. Very superficial measurements. Think of it like this, before the Palma Vista, we were looking at the top of an iceberg in the water. We had no clue what was resting underneath. Now we have eyes inside the lung, where I don't feel that we'll ever need any more to challenge the lung and possibly hurt it and not optimize it before we pull it. Send me some comments down below. Maybe I'm completely wrong. I think this is a great discussion piece. Again, this is my personal opinion as a professional. So what do you guys think about what I just said?